Very good evening, all the doctors.
Thank
My name is Khushbu. I represent Aries today for this program. I am heading marketing of cardiac team at Aries. So, on behalf of Aries Life Sciences, we would like to welcome all of you to the today's session of Crevast Academy. As all of you are aware, at Aries we believe into power of empathy, truth of science, and by this in the mind, we always try to endeavor to have our efforts towards the patient care initiatives. And we are very proud to share that we as a company are number one in terms of patient care. And this all of this we are doing for improving patient outcome. So to name a few initiatives, we have Holter on call, ABPM on call, sleep study on call, India Heart Study. These are few initiatives which we run in the field of cardiology. So, just to give you an overview about Crevast Academy, it's a round-the-year event wherein the content is curated to disseminate and master the nuances in clinical management for improving cardiovascular outcomes. And through Crevast Academy, we endeavor to guide clinicians across India to improve cardiovascular health in patients. So these are the earlier Crevast Academies which we already executed in the past, starting from the last year. So there have been 12 sessions of Crevast Academy, which have been discussing in and around the lipids, statin. So we discussed about statins for diabetic heart, statin optimization, statin associated muscle syndrome, the hidden threat, low LDL but high CV risk, high intensity statin therapy. Then something on the lipid puzzle, holistic approach to dyslipidemia management. Then aligning the expectation versus reality, lipid management. Then CVD epidemic in India and navigating heart health, key factors shaping the cardiovascular outcomes. And the last session which we had was more dedicated towards the clinicians, doctors, which discussed about the cardiovascular health and the importance of CV health among the doctors, clinicians. And for today's the session, the topic of today's Crevast Academy is CSI guidelines and interactive discussion on interpretation of lipid profile reports, as well as the key points from the CSI guideline, as well as focusing on the statin optimization. We see as a company also, we feel that a lot of eligible patients are not getting statin at a right dosage. Though the important medicine is available in good amount in our country, but a lot of patients are either not taking it, or the adherence is not there, or the optimization is still to be done. So for today's session, Dr. Sanjeev Shah is there. He is moderating the today's session. He is an endocrinologist based at Nanavati Mix Super Specialty Hospital, Mumbai. He has more than 40 years of experience in private practice, academic clinician, as well as private practice. He was associated with KEM Hospital as a clinical pharmacologist for more than 5 years, and researcher in many global trials for more than 20 years. He has published more than 50 original research papers, and he has more than 20 book chapters with his name. So from here, I would request Dr. Sanjeev Shah to take over the today's program and take us through the today's Crevast Academy. Thank you.
Khushbu, my slide is visible.
Yes, sir.
It's the same slide which you have shown. It's my pleasure to be part of a 13th clinical teaching program under Crevast Academy. We have two parts. The first part is going to be focused on CSI guideline. And later on, we will have in the second half of a program an interactive discussion. Everybody knows that LDL cholesterol is the culprit, which is responsible for slow progression of atherosclerosis. An individual gets diagnosed as a coronary patient only when an event happens. Though the atherosclerosis is progressing, but he doesn't get a label of a disease individual who needs an intervention. And the real target used to be LDL 100, which got shifted to 70 for secondary prevention. And in recent years, all the experts believe that we should have 50 milligram as the target, probably based on some of the evidence that plaque formation could be prevented if you get lower and lower LDL. The most difficult challenge in practice that patients are not subjected to any kind of cardiovascular risk, and so they remain either untreated or being treated suboptimally. If you are aware that plasma cholesterol starts increasing right after the age of 1 year, LDL cholesterol and total cholesterol are much higher. And from younger adulthood, many people require an intervention, but they are even not screened, they are not diagnosed, and that remains a different challenge than the people who are 40 to 80 versus 20 to 40. We would not go into the debate of all those. Simply to put it, I have two real expert faculty today. Dr. J.P.S. Sahni is a chairman of Department of Cardiology at Sir Gangaram Hospital in New Delhi. The board member, ethics committee member, executive board member, more importantly, appointed as a chairman of Lipid Council of India by CSI. And he had been instrumental compiling all Indian data to make a first time a very important CSI guideline on management of dyslipidemia or all lipid disorders. He has more than 220 publications, the fellowship of multiple cardiology and heart association. He would address on CSI guidelines. Joining with me today in the second half would be Dr. Ashu Rastogi. He is an endocrinologist in the faculty in the Department of Endocrinology at PGI Chandigarh. He is a young investigator award from 2015 to 2019, different awards. He had been a secretary of two different associations, RSSDI and Diabetic Food Society of India. His interest has resulted into 140 publication in various index journal at very, very young age. So he is a dynamic endocrinologist from north of India. And I invite Dr. J.P. Sahni for a key talk on CSI guidelines, what can be presented with a little shortage of time, but we would take a few points during discussion again. So here I stop sharing my screen. Dr. Sahni would share his screen for his talk. Over to you, Dr. You are mute, Dr. Sahni.
Thank you, Dr. Sanjeev Shah. Thank you, Khushbu, and giving me this opportunity to discuss. So I think let me go straight away because of the interest of time. You can go for yeah. Yes. So this was the guideline which we just released on 9th of April. And press conference was done on 4th of July this year also. This was my colleagues, those who have helped me in writing this document. This is the executive summary, which is published in Indian Heart Journal supplement now. And so why there was a need of India-specific guideline, we started looking into almost 4 years ago. We found that, are we different? That yes, probably looks like that we get a disease 10 years earlier, and more than 50% are less than 50 years of age, even 15 to 20% less than 40 years of age, 3 times more than the Western population. But the cause for this, probably we look into our own data of our country, we found probably we get hypertension, diabetes much earlier compared to Western world. Tobacco consumption is high because the cigarette smoking may not be that high now after the government's intervention, but tobacco chewing and BD smoking still rampant, a unique problem of our country. Metabolic central truncal obesity, central obesity is almost 2 to 2.5 times more than of the Western world, which probably leads to increased atherogenic dyslipidemia, high TG, low HDL, and high small size LDL cholesterol. Again, a unique feature of our country. Good data of our country based on from my hospital only, genetic data of familial hypercholesterolemia as a cause of young MI, and then lipoprotein little a, which is again highly prevalent in our country compared to Western world, probably are also contributing significantly to a young onset of CAD in our country. Finally, look into the data of lifestyle food habits of the various parts of the country. We found that the unhealthy, the sedentary habits are highly prevalent, unhealthy cooking, the dietary patterns, probably taking a lot of carbohydrate food, because many people are vegetarian. Probably that also adds to that. So we found these are some of the features which made us we are unique to the compared to the rest of the world. So we decided that for the first time a guideline customized to Indian population. However, we concede that at many instances hardcore Indian data was not available. We had to tweak the international guideline of ESC 2019 with the help of expert opinions of experience of my colleagues in the field of lipidology. We have good data from epidemiology, clinical trials where Indians have participated, genetic study, and small studies done on the role of statin in reduction of LDL cholesterol. In the absence of our own risk calculator, as we know, most of the risk calculator from the Western world, they underscore us. So we have used only risk factors for future estimation. And my plea to my other colleagues, those who are interested lipidologists, we should work together to develop our own risk calculator in future. So let me start with the just key points I will discuss, which are relevant for the management of dyslipidemia. So we started looking into how is the prevalence of lipid is different in our country. This is a good paper by Dr. Mohan and his daughter, which this is published in just June 2023 on 113,000 population for urban and rural area. Hypertension present in 35%, diabetes in 11.5% of the adult population. But look at the lipid. It is 81% of the people in the country are having dyslipidemia, mainly driven by low HDL cholesterol and high TG. And this was the data from for the high cholesterol and high LDL cholesterol. We found there was a high prevalence in the northern states, the Kerala, Goa, and to some extent in West Bengal, almost similar between the LDL and high cholesterol levels. And found there was the inter-state and inter-regional variations were also existing. But look at the triglyceride and low HDL cholesterol. Whole country is red. There was not much of interstate or regional variation, and maybe less variation between urban and rural area also. And this was the incidence. And when we look into the data from the urban area, the LDL above 100 milligram was seen in almost 50% of the adult population. And non-HDL, since the high TG is existing in the society, we started looking into non-HDL cholesterol and found in almost 55% of the population. So we started looking how to manage. We do not have risk calculator. So we decided, since we have atherogenic dyslipidemia, high triglyceride cholesterol, so we decided that the goal estimation should include not only the LDL cholesterol, but also non-HDL cholesterol if the level of triglycerides are above 150. Now, in this guideline, this is practically similar to that of ESC guideline, but there are certain areas where we pitched in. Like extremely high-risk population, ESC says getting recurrent events in the same territory or adding another territory. We found our own experience of last 5 years that patients, those who have young heart attack, as you said, 50% of population, having associated familial hypercholesterolemia and elevated LP above 50 is the extremely high-risk population. And there we considered to keep it below 40 based on the Odyssey trial or below 70 for non-HDL cholesterol. For very high-risk population are similar to the guideline, any ASCVD imaging showing more than 50%, 2 lesions, diabetic more than 20 years, the familial hypercholesterolemia with risk factor and CKD with risk factor to keep it below 55 and 85 for non-HDL cholesterol. In high-risk population, since the diabetologists are with us now, and we have learned now that any diabetic, or in this guideline, we added hypertension, which was not there in the ESC guideline, based on our experience and also data from HOPE-3 trial, that if you're having diabetes and hypertension, since we know the final common pathway, as Dr. Shah has shown in his very first slide, is the entry of the LDL cholesterol into the atheroma formation. Who pushes? Diabetes, hypertension, smoking, and stress. So what we found that if you have a diabetes or hypertension with one risk factor or target organ damage is there, then keeping it below 70 is the way, not keeping it below 100. That is not enough, because that will create more and more recurrent coronary events. which was clearly proven in the HOPE-3 trial. The low-risk population without risk or single risk factor, we wanted to keep it below 100, not 115, which is given by the ESC guideline. Now, coming to the another important area where we differed with we modified our guideline was the management of acute coronary syndrome. Here we suggested every patient who enters into the hospital or nursing home with ACS should get their lipid profile along with the initial blood test. Unfortunately, most of the tertiary care hospital patients, they get discharged from after ACS, and there is no lipid profile in the discharge slip. So this is the most important thing, because that will help us to know whether this risk factor has played a role or not. And here we decided another thing, that we've decided to put the high dose of statin, either 40 Rosuva or 88 Orva, along with ezetimibe combination to begin with. So that slogan is hit hard and hit early, keeping it below 55 by 3 months. Otherwise, there will be recurrence of atherosclerotic cardiovascular disease or ACS. And why we chosen the second lipid profile to be done after 4 weeks? Because our own study, which we did on 400 patients, have clearly shown the peak action of the statin comes at 4 weeks. Beyond 4 weeks, there is no further reduction of the cholesterol. By 14th days, the 2 weeks, 70% reduction of LDL comes, but the peak action comes at 28 days. So we thought, if you want to act early, do another lipid profile at 4 weeks. If you reach below 55, we are okay. If not, add bempedoic acid at this stage. And after another 4 weeks, it's still not, then add other PCSK9. And now we have inclisiran injection, which is available to us as a distinct advantage. 2 injections a year, PCSK26 injection, no LDL variability, and cost effective. So that's what we thought. But the another interesting finding which we found in our study was that many of the patients in our own single center study of 3,800 patients, that when they follow them up over a period of 1 year, most of the patients from high dose of statin, only very few people at high dose of statin at the end of 1 year. So we decided how to logically reduce the dose of statin from 80 or 40 to 20 is one, if a patient gets myalgia, or if a patient has HbA1c, and we have 40 to 50% patient metabolic syndrome with pre-diabetic state, then if the patient shows a rising trend of HbA1c from 6 to 6.4 or 6.3 or 4, that means this patient is likely to get a new onset of diabetes. Again, we decided to reduce the dose from 40 to 20 or 80 to 40, and then we can discuss that. And then repeat the lipid profile. If the levels are above 55, add bempedoic acid. Now, in this study, so this was the study which we did both in North and India, that if a patient has baseline LDL at entry point above 110, then what we found, that if you give only high dose of statin, only 50 to 55% could reach the goal of 55 at 4 weeks. But if you add ezetimibe and high dose of statin, then around 75 to 80% came to that level. So this was the study which was baseline was around 130 to 140 milligrams. But this was so that made us feel that we should add this, and then later on we can reduce if there is a need for, because of side effect. The other area which we unique to our guideline was chronic coronary syndrome, or chronic, the patient with atherosclerotic cardiovascular disease. Again, lipid doing at fasting or non-fasting state, starting with a high dose 20 Rosuva or 40, or if patient is already on that, add ezetimibe rather than doubling the dose to 40 and 80, because we know if you add ezetimibe, then you reach the goal early, because it reduces LDL by 15% as against 8% by doubling the dose. The compliance improves, the side effect of myalgia and new onset of diabetes also reduced because it is dose dependent. So this is how we thought we should go with that, and don't double the dose, go with 20 plus ezetimibe, 40 plus ezetimibe. If not reached, then add bempedoic acid, or you can add inclisiran or the other good problem. Here we are not in hurry, because the annual rate of coronary event is only 2 to 3%. So you can go gradually, but keep on doing lipid profile at 4 weeks for that, as we have suggested. Then coming to the area which is specific for our guideline was high triglyceride. Whether shall we treat it or not? We should treat it, because we have a definite evidence now that triglyceride up to 400 to 450 is very important cause of which contains remnant cholesterol and can cause increased atherosclerosis. And for that, we decided that the triglyceride should be looked for that. And this is the data from the Western world that in spite of reaching the goal of LDL below 55, 25% patients have TG above 150. And in our country, it is 40 to 50%, a big number. Up to 450 to 500 triglyceride, there is a chance of increased atherosclerotic cardiovascular disease. So because of this ideal cholesterol, a small B48, and the size of the LDL becomes small because of high TG. So TG should be treated. And for that, we have decided if the TG is above 150, look for non-HDL, which is nothing but total cholesterol minus HDL, and it is 30 milligram more than the LDL cholesterol. And this is the algorithm we decided. The patient comes to you with high triglyceride, has no atherosclerotic cardiovascular disease, non-diabetic, just high triglyceride, lifestyle modification by reducing the carbohydrate diet, saturated fat to some extent, alcohol abstinence, tobacco cessation, increased physical activity with weight reduction will generally take care of this triglyceride and do not need any drug. But if you have a triglyceride, in spite of all lifestyle modification, and you are having diabetes or atherosclerotic cardiovascular disease, the drug of choice is statin. And in statin and diabetic population, we always suggest that to add HTMI, because that the IMPROVE-IT trial have clearly shown as combination of HTMI and the statin works very well. But in spite of that, if your non-HDL cholesterol is not reached to the goal, then add what we say the IPE or eicosapent ethyl, what we say EPA part of the fish oil, not the DHA part of the ASR. And that's it. So here we are working between 150 to 499 triglyceride for atherosclerosis prevention. But suppose there is no role of fenofibrate here. But if the levels are above 500 to 1000 or 2000, then there is to prevent pancreatitis, because this is the third commonest cause of pancreatitis after alcohol and gallstone. And here, the intensive lifestyle, very low fat diet, and fenofibrate are the drug of choice here. We should start them on this patient to reduce the number of triglyceride. Here, we are not worried about the non-HDL. We can reduce it below 500, then do another lipid profile to add statin. But adding saroglitazone and fish oil again is a good drug to be used in this situation. But the saroglitazone, our own drug, which has no endpoint data at the moment available, the safety data is available, and now FDA is looking for this for MEFILD or NEFILD group of population. So if a patient has high triglyceride, in spite of control of diabetes, saroglitazone is a good drug. If you have a NEFILD or MEFILD, along with high TG or alone that, then saroglitazone is also a good drug. But in spite of that, your TG is not coming control, then adding the injection Volasertib is now available in Western country, and now NHPLAT3, even Ucnabal is also available in the Western country, which we do not have at the moment. So this is how we thought that we should try to manage patients, giving a most important message: do not use fenofibrate unnecessarily. That will increase the side effect of statin. Use rather saroglitazone in that situation. Now, another important area which we faced in our country is, do we need a uniform lipid profile reporting for labs in our country? We have more than 3 lakh labs. Only 2,500 labs are NBL accredited. So what we decided, that every lipid profile report should be uniform in the country. I think this is one of the important reason of uncontrolled lipid in this society, and people get recurrent coronary arteries. This is one of the important risk factors for recurrent coronary events. So what decided, look for your risk and corresponding targets of lipids in values. So what I will show you an example of this patient who came to me a few days ago. After 3-4 months, he came to me and I asked him that, show me the lipid profile. He had a heart attack a few years ago. And when he showed me lipid profile, LDL was 90. This is our hospital lipid profile report, which shows less than 100 normal. And he said, sir, my lipid is normal. I said, no, because you are a patient of CAD. He said, what? So I said, look into this chart. In this chart, you belong to a very high risk group. A very high risk one is the who has got blocked artery in any area, but brain or leg artery or heart arteries. So very high risk means you look at your level has to be 55, not 100. So that's how we have to increase your dose of statin now. So he understood that. So such type of uniform lipid profile report is a must for whole country. Unless and until we do that, because there are many laboratories, they give a range, 80 to 140 for LDL or 70 to 130, something like that. No uniform ranges are there, and patient get totally confused. And that is one of the important risk factors of recurrent coronary event in the society. I have seen this. I have got experience of doing that. And that's why we become and we are on 8th of August, we're having All India Biochemistry Lab and Laboratory meeting where we are going to project this slide to request them to keep the lipid profile slide with a small table only, which becomes very easy to read. Look for your risk and corresponding targets of lipids. And then you think what is your level and try to go to your doctor and tell him that they should adjust your doses. So now finally, just very briefly, we have some 5-7 minutes time. Let me also go through the genetic causes of dyslipidemia, which is very important. Familial hypercholesterolemia, fortunately, heterozygous is 1 in 250, grossly underdiagnosed, undertreated clinical entry. Homozygous, fortunately, is very rare, which we'll discuss later. And what we found, the genetic testing is the gold standard of diagnosing familial hypercholesterolemia, but the genetic labs are not easily available. So what we have now learned, and globally people are now using Dutch Lipid Clinical Network criteria for familial hypercholesterolemia. This is a scoring system. Young MI below 55 men or below 60 women, you get 2 score. Going to the family history of similar type of disease in the same age group, you get 1 score. But you should have the experience of taking the family history. It is not the family history of cardiovascular disease, which includes the heart attack and stroke and peripheral vascular disease, history of sudden death. That is also important. We should ask them. And many times, if you superficially ask patients say, no, sir, I am the alone person in my family. But you go and spend some time, you will find 1 score you will get easily. Look at the lipid profile, above 150 to 190, 1 score, above 190, you get 3 score. And the score is above 6, which includes the definite and probable group combined together, 6, which has been validated with the genetic scoring, is almost sure that this patient is suffering from familial hypercholesterolemia. The other important physical examination, what we found now is arcus cornealis. It is a grayish deposit over the cornea, not commonly seen in the lower eye, more commonly seen in the upper part of the eyelid. You just have to lift the eyelid. And there is an adjustment score which is available for that. So this becomes a very handy, just like Chad West score for atrial fibrillation, we have now this tool available to diagnose FH. Why it is important? And this is the adjustment score. If a patient is already on statin, 30% of patients are on statin. In that situation, we have to use this adjustment score of atorvastatin and ezetimibe available for different doses. For example, my one patient came to me a few months ago with acute MI. He was already on 20 milligram atorva and non-fasting LDL came 110. So adjustment score for this to calculate Dutch lipid clinical criteria is to multiply with 1.8, which came to 198. 198 means score of 3 for lipid profile. This is how this is useful. So why the FH is important? Because we are not only treating the index case, we have to go for the cascade screening of the sibling and their children, looking at the non-fasting lipid profile. Above 135 for children and above 150 for adult. If it is there, he is a carrier. So by diagnosing a case of FH, we do not identify a case, but a family at risk. So in my experience of 1,500 patients of FH now, we found on average from one index case, I get 2 more carrier in the family, and we are putting them on statin to prevent cardiovascular disease. This is our experience of 1,200 patients at the time, and we look into the 1,200 patients, 17% of the population have got FH in young heart attack population. And when we look into the risk factors associated with FH population and LDL cholesterol, you can see very interesting finding that those who are having diabetes, hypertension, smoking, these are much more prevalent in non-FH young heart attack patient. They are less commonly seen here. But look at the total cholesterol is very high in definite and probable group. The score is above 6. So what we learned from this study was that one should suspect FH in every young heart attack patient who has got elevated LDL without associated risk factor. That means the patient has no smoking, patient is not diabetic, think that this may be an FH because you can save few more lives. So this is our guidelines algorithm. Young MI, put Dutch lipid clinical criteria, score 6 and above, heterozygous. Treat generally most of these patients, they have very high cholesterol, need 3 drugs. The ezetimibe, high dose of statin, and even bempedoic acid. Don't reach goal, then add the inclisiran or the Irocumab. But the treatment doesn't finish here. You have to do cascade screening, look for the children and their brother, sister, look for that, and then look for the LDL cholesterol, or maybe if genetic testing possible for children, and try to treat them so that we can prevent future cardiovascular disease in the society. Coming to the last part, LPA, it is highly prevalent in our country. 25% general population compared to 15 to 20% Western report. The level above 50 milligram is considered high risk population. 1.4 billion population in the world is suffering from this lipid disorder, which is the number one cause of genetic cause of dyslipidemia in the world. And we have good data to show now from all the studies, epidemiological study, clinical study, that if you have LPA above 50, your chance of heart attack is 3 to 4 times, aortic valve disease is 3 to 4 times, 1.5 times increased stroke, cardiovascular mortality. Unfortunately, there is no treatment available at the moment for this LPA little high, which is the statin, ezetimibe, bempedoic acid do not have any role to play. PCSK9 incretin, they reduce only by 25%, which is probably not enough. And this LPA directed therapy is called pelacarsen, and olpasiran is now ASO, the antisense nucleotide, and the small interferon RNA group of drugs are being evaluated. Next year, we'll get the result of Horizon trial. If drug comes positive, this is going to reduce by 80 to 90% LPA, and probably this will result in increased cardiovascular disease. Our own study, which we did for LPA over the last few years, of more than 1,000 patients with atherosclerotic cardiovascular disease, have shown LPA above 50 is much higher in younger heart attack population compared to the elderly hypertension. It is associated with severity of the disease. Triple vessel disease, diffuse disease is much higher in the patient who has got high LPA. And those who have got FH, along with young heart attack, then the LPA association is 43%, much higher. So two genetic risk factors are very common in our country, which explain the premature heart disease. So to conclude, dear friends, Dr. Shah, for the treating physician, this executive summary, which I've just very shortly did not discuss about the drugs, the diet, and so many, which we'll take up during Q&A section, is very important for the physician. We have tried to cover each and every aspect of this guideline. However, in many areas, we use the expert's opinion also. And our guidelines not much different from the European, but there are areas where we have tried to change it and according to our system, like starting the lipid profile at the age of 18 years. So what we believe, what the USC believes, earlier the better, lower the better, longer the better. But we have added together the better. I mean that statin and ezetimibe combination works much better. LDL and non-HDL combination works much better in this population. Thank you very much. Over to Dr. Saha for your future work. Stop sharing the slides now.
These are your slides, which
Yeah, I think there will be some
they were
questions
sent to me
coming.
also. So I will have to go a little. Right. So thank you, Dr. Shahni. It was very quick and very fast. I would recommend all the listeners to carefully look at each paragraph, study properly, and make your own notes, what you are doing right and where you are missing. Correct, Dr. Shahni?
Yes,
People
sir.
will
Yes,
have
sir.
to go very carefully.
Yes.
So in nutshell, we would try to take up some of the points, but we have just half an hour and we'll touch about 8-10 important points. This is how we order a lipid profile. Most people agree that we routinely do not need apolipoprotein. If the lab gives you non-HDL, we should try to read more frequently a non-HDL because that takes care of an Indians who are at risk, who will have still higher non-HDL. Now, these are two lab reports where Dr. Sani and Dr. Ashu, Dr. Rastogi, you are there. We can't see you.
I am there, sir.
Yeah. So on the left, you find LDL cholesterol normal range less than 130. while on the right it says it should be less than 100. And Dr. Sani pointed out in a patient for secondary prevention, ideally it should be much less. So Dr. Sani, you pointed out in relation to interpretation. Now, these are the kind of prints, normal, high, qualitative words like optimal, near optimal, borderline high, very high. How do you interpret when you are addressing biochemist? Why can't we simplify this language? Quick comment. Dr. Rastogi will answer after you answer.
Okay, so I think that's why we had a good discussion almost for more than a year with my colleagues during this phase of preparation of this manuscript, and also we have pitched in the, I must admit that, the lipidologists from the Europe also, and they also added to our meetings and all, and where we come to the conclusion, let's make everything simplified. So the physician should get a clear answer. There should not be any ambiguity and should not, and make it simplified. So writing borderline, highlight, it doesn't make any matter of this. That's why we made a simplified paragraph, a simplified table, where we said whether you belong to high risk, very high risk, or low risk population, and accordingly, what is your goal of LDL and non-HDL. So that simple, which I showed in my slide, becomes a very easy reckoner. Only thing, we have to put an asterisk over the LDL, where you should say that please look down and look for your risk and your goal. Then you will get your appropriate answer. So instead of saying borderline, borderline high, extremely risk A, B, C, or one of those, I think that general common population will not able to understand much about that. So give them a very specific that it is goal is LDL, maybe non-HDL if your triglyceride is above 150. Then I think a simplified way will be the best way to convey to the all the laboratories in the country and also to the so that's why during our press release, one of the key point of discussion at that time was with all the newspaper and TV channels, but this only, that make it simplified and very easy to understand the lipid profile. Otherwise, patient will be not able to know what is his goal.
Half of the reports are interpreted by family physicians and non-experts, not even consultant physician. So let's
Yes.
ask Dr. Rastogi, you practice endocrinology. 10% of diabetic population in our country, which is already a high risk, as mentioned in CSI guideline. Does the interpretation is different for you? Because every patient of yours and every patient of mine is a diabetic who runs so-called kind of an extra risk.
Yes, sir. So just a comment over the prior question also. So as Dr. Sani was mentioning, I absolutely agree with it. And all the lipid report, whatever the patient is carrying in his hand, is very individualized. He can have a value of 70, he can have a value of 90, and he can have a value of 110. The interpretation would be entirely different from each and every different patient. And I'm really appalled by how do these laboratory people give a value and they highlight it, and that creates an alarming situation. And sometimes when it isn't really alarming, it is not alarming on the basis of the report that the patient has, and he doesn't then consult a doctor on the basis of that. And we know that now it's very common that everybody is having their executive kind of the checkup where they do lipid profile, but they might have a value of 110, and as rightly shown in one of your slide, that they have written normal as less than 130. So patient is very happy, but he doesn't know that he is at high risk because he already obese, he is hypertensive, and unfortunately, if he is diabetic, 110 is always a red flag sign, no doubt about that. So this question is very pertinent. Whenever we see a patient of diabetes, there is no role of this low dose statin therapy, and we all know about it in patient with diabetes. So all our patients are at least high risk, and many of our patients at very high risk for ASCVD events. So my interpretation, whenever I see a patient of diabetes who comes with these kind of lipid reports, is to categorize them into high risk, very high risk, And definitely on the basis of that, and as Dr. Sani was mentioning, we also follow the same kind of targets, whether it is less than 40 of LDL, less than 55 or less than 70. I don't see, maybe I might be biased because I sit in a tertiary care hospital. We don't see less than 100 as a target for patient of diabetes, because almost 80 to 90% of patients of diabetes have hypertension. No doubt about that. They have obesity as per the Southeast Asian cutoffs of BMI or waist circumference. So if they are having one ASCVD risk factor, they have diabetes along with that. I don't see that less than 100 would be an ideal target. Less than 70 has to be there. And then further on, it may be less than 55 or 40. So this is how I see the patients.
Thank you, Dr. Rastogi. I and Dr. Sani see the patients in Mumbai and Delhi where air pollution is like a passive smoking, and we add an additional risk factor there. Now, many reports in our country have LDL by calculation. There are 3-4 different kind of formulas. Fridwell formula has been used far more frequently, which calculates LDL. So, Dr. Sani, we have a question for you. This is a patient of 57. TC is only 141, but calculated LDL was 53, while directly measured was 84. Now, this was a patient who asked for a reduction in a statin dose based on the Fridwell formula. So at which level of LDL you would request for a direct estimation?
You see, the very good question, very practical question. You can see his report, the triglyceride is 205. You see, earlier the concept was to calculate non-HDL if the TG is about 200. And when we discussed with all the lipidologists from USA and Europe, they said this was an arbitrarily, we were wrong. It should be above 150. So if you look at this patient, his total cholesterol is 141 and the HDL cholesterol is 47. So non-HDL comes to approximately 93 or 94, something like that. So that shows it is a high for a atherogenic cardiovascular disease. It should be below 85 for a patient who is suffering from atherogenic cardiovascular disease. For a patient who is alone diabetic with risk factor, then it may be okay because it is less than 100 for non-HDL and less than 70 for the LDL. So here, as Dr. Rastogi just rightly said, the most of the patient in clinical practice, not only of diabetes, I even see with hypertension, they have one of the risk factor associated. And risk factor, what we said was truncal obesity, hypertension, diabetes, smoking, and family history of premature disease. If you have any one of them along with that, we decided to keep it below 70. And what we found, and I'm sure in your experience, that most of your diabetic patients will require statin to keep it below 70. Many patients of diabetes, probably they have always above 70 LDL cholesterol. So here in the situation when the TG is high, we generally look for non-HDL, and which is very easy because there is no need of fasting state here. Because fasting and non-fasting does not make any change in total cholesterol and HDL cholesterol. So total cholesterol minus HDL is non-HDL cholesterol, which is not at all hampered by the fasting and non-fasting stage, but it is a good estimation in a patient whose TG is above 150. So target non-HDL in such population. The other mistake what comes in the clinical practice, when the patient is given statin and non-statin drug or fish oil, they started looking at the number of triglyceride. It should not be done. One should look at the number of non-HDL cholesterol. Reduction of triglyceride number is relevant above 500 triglyceride level. So that is a common mistake happen. When I've added fish oil to my patient, it's a very expensive drug, sir. And when in the end of the day, he comes, he said triglyceride from 270 has come to only 230. I said, look at your non-HDL, which was 130 has come to 94. We are looking there, not looking at the number of triglyceride. So these are the common problems which do face. And second thing, when our patient comes to you, many times I've seen my patient have reached the LDL of 48. I was very happy that the doses of statin, but I forget to look at his triglyceride. And when I saw his triglyceride, it was 232, and I calculated his non-HDL, it should have been 85, it was 104. So I have to step up the dose of statin or add H-tamine. And in diabetic population, I always believe Adding HTMI to statin modest doses is the best way to reach the goal below 70 or below 55 if the diabetes is long-standing with multiple organ damage. So that's why I think we should not forget to look at non-HDL in clinical practice, which is a remnant cholesterol, a very important cause of atherosclerosis.
So we will take some time to add up that everything is focused on non-HDL. Currently, we are still focused on LDL. So
Yes.
Dr. Rastogi, this is for you. In most diabetics, triglyceride could be high. So this is one paper in India which looked at Fridwell calculated versus direct measurement. And there is a recommendation in relation to high triglyceride seen in diabetic population. Your experience with such kind of a situation?
Exactly. So hypertriglyceridemia is really, really very common, and unfortunately, with the uncontrolled diabetes, it is furthermore expected, because we know that insulin is the best hormone that is responsible for TG reduction. So in our patients, as rightly mentioned by Sani sir also, TG we have to look at. Earlier, maybe 10 years behind, we were just focusing very much on LDL and we never looked at TG. Maybe because the outcome studies were not there, but fortunately now we have outcome studies, whether it may be reduced trial and other with definitely certain kind of drugs for TG reduction. So whenever we see TG, which is more than 200, or I would say even more than 150, our lab, we measure direct LDL cholesterol. So, but when the patient comes with a certain kind of reports, and I have many times seen that they never mention that whatever the LDL, it is written on the report, it is either a calculated LDL from Friedwald equation, or it is just a direct LDL. So we stress upon that, and your previous slide already mentioned the discrepancy between the measured LDL and the direct LDL. So if the TG is more than 150, here some people say it is more than 200, but even at 150, the LDL is likely to be miscalculated by the Fredwald equations. For theoretical purpose, it is 200, but for Indian population, almost, and even shown by Dr. Mohan's study also, that hypertriglyceridemia is again the second most common lipid abnormality after low SDL in Indian context. And we have a mean triglyceride level in diabetes population roughly between 180 to 190. So almost 60 to 70% of patients are having high TG levels. And we have to be very meticulous about interpreting LDL cholesterol report, even if TG is more than 150.
So some patients will need a repeat estimation in a good lab, which gives us a direct LDL.
Exactly.
Dr. Sani,
Yes, so
another concept which
my take on is that when we were preparing our guideline, we were started looking into this fact. When we said instead of 200, we'll make it 150 above, we look for non-HDL cholesterol. And as rightly I just said, then it becomes irrelevant at that stage, whether you're having direct or indirect calculation. We are not bothered. We are looking at non-HDL cholesterol. Yes, for a patient who has got TG less than 150, there the Friedwald calculation is not that bad. It's just fairly okay. But still, people believe that direct calculation is good. But the lab's reliability on the direct estimation is also variable. So it has not been very well standardized. That is the issue. So we thought, let's take an easy approach. Total cholesterol minus HDL cholesterol is non-HDL cholesterol, which is not at all affected by it is affected by triglyceride, no doubt. That's what we are working for. So don't look for direct or non-direct. We are not bothered. Look for non-HDL, which is okay.
yeah, so probably we'll evolve into looking at that particular line.
Yeah.
Now, this is another evolving concept that in many people, CV risk calculator does not give you high risk. And so people remain untreated. On the other side, lifetime exposure of an LDL is a new concept relatively. And there are some elegant papers by Kaushik Ray and others who have written in such a nice way of treating any LDL at any stage, whether younger or elderly. Now, I refer to this particular, as you mentioned, ESC 2019 guideline, most reliable. In the right box, there is high risk and very high risk. So this kind of a risk stratification, even here I put it, On the other side, people don't practice ASCVD scoring or Q-risk scoring. Nothing is happening. And so the LDL is treated with low intensity statin. Dr. Rastogi mentioned about moderate and high intensity in diabetic people. So 3 questions which are very, very important. Is the risk of Indian population going down or up? Why risk assessment is not in practice? People who have not suffered from any event, and any method to accurately risk assessment in order to achieve LDL goal. So this brief answers what you can give one after another.
Yeah. So Dr. Shah, what I said, that first slide where we just referred to Dr. Kaushik's paper and other colleagues' paper, that is the 8 gram of cumulative LDL, which gives you atherogenesis genesis. That's what the paper says. So if you are having 100 milligram of LDL, you will take 80 years to reach 8 gram. Now, familial hypercholesterolemia, they generally have around 250 to 300, so they get around 35 to 40 years. The homozygous, they have generally 450 to 500 LDL, so they get disease around 10 to 15 years. This is because of the cumulative comes to 8 gram much earlier in homozygous than heterozygous and then to the general public. So if you keep your LDL 80 from the very beginning, because of genetic benefits you are having, or you are taking a drug to reduce the LDL to below 80, then you will live, according to the story, you will live 100 years, because the 8 gram will come at the age of 100 years, something like that. So that's why one of the very interesting paper of Dr. Brown was saying that inclisiran should be given to such population to reduce only one injection that will reduce 20% of the LDL, and you reach below 100 up to 80, and that can go. So that's the cumulative paper which came, which is a very interesting fact. And this has now been proven that in the lifetime risk, which is very important. So coming to the question which you're having, is the risk of Indian population going down or up? I think if you look up I'm sure you, and since we are cardiologists, in my CCU, I will tell you, I am really surprised to see a significant number of population getting heart attack below 40 years. I mean, that is what we are finding, a younger population getting heart attack, which we used to say that probably may not be true, but now we found Indian Heart Study and everywhere, we find that is going. So the younger age coronary artery disease is going up, no doubt in that. Probably we accumulate risk factor earlier and we don't treat them adequately, and we have a very poor lifestyle also. And we forget to look into the lipid profile of most of the population, because the reason what we've said in our press conference, that hypertension has some symptom, diabetes has got some symptom, cholesterol has 0 symptom. It is a true silent killer. Unless and until you do a lipid profile, you will not able to know your risk. So that's why we suggested, as the child goes to a college, he should get his first lipid profile. Unlike the Western literature, which is 35 or 40 years, we say 18 years because we get risk factor earlier. And every child should know at the age of 18 that what is his blood pressure, what is his sugar level, and what is the lipid. Lipid cannot be known unless until the test has been done. So that's why I think if you follow this method, try to treat this. And then the article which was written by my colleague, Dr. Jamshed Dalal, and took us again 1.5 years to go into the details of management of lipids in young adults, 18 to 40 years of age. And you found difficulty because the young, less than 40 years getting a heart attack, targets are same, less than 55 or 40, whatever. A patient, the carrier of familial hypercholesterolemia, fine, we have to treat them above the age of 2 years now, or even 5 years people. Or I've got 18 children with me now, those who are on statin. Very small dose of statin, 5 to 10 milligram, and their levels are below 135, which is now advocated by the ESC guideline. And the third one is a group with young people between 80 to 40 years having multiple risk factors like hypertension or diabetes, for example. They have to keep their level below 70 like an adult. So we are not different from them. Only area where we are different from primary prevention, what you are made that question, is a young patient comes to me, a young executive, 28-year-old. He says, my LDL is 145. Sir, I don't have family history of premature heart disease. I'm not diabetic. I'm not hypertensive. And I have done calcium score, which is 0. So shall I take statin or not? That was the question which comes to your mind. At that time, many top lipidologists in the world have come to the conclusion probably we should reduce his LDL. If it is 145, it is certainly high. He may not be having it. So if you're treating a child at the age of 20 with hypertension, treating a child of 20 years with diabetes, why you are not treating a child 20 years with 150 LDL cholesterol? So that was the argument and logic which came, because there is no associated risk factor. That's why the reason probably he's at low risk. And starting them on statin, and now people believe if you don't want to give statin, give non-statin, give bempedoic acid, give ezetimibe. Some people believe give nutraceuticals, which are available now, berberine or bergamot or Chinese red yeast rice. But studies are not very adequate at the moment to give the final point. So for primary prevention, answer is simple. If the level is above 190, irrespective of age, around 10 years or above, we have to give them statin. 160 what the guideline says with risk factor, give them statin along with lifestyle modification, which I believe, or we believe now, our expert, that it should be above 130, not 160. It is too late for that to come to that. So that's how the primary prevention area is still. We need a lot of work in our country to look into this fact, which we could not found any data from our country on this area. So we need help from all of you to manage such type of primary prevention population. And accurate risk assessment, as I already told, we do not have any risk calculator of our country, unfortunately. And Framingham risk score, JCB, score 2 system, quick, any risk score you apply for Indian population, it underscores, because the scoring system starts above 40 and we have 20% people getting heart attack below 40. So that underscores us. So we have to build up in future the risk assessment score for specific for our country.
And Dr. Sani, ARIS, another division, is currently working on Q-Risk 3. They calculated for 10,000 doctors risk scoring, and they found almost 38% of the doctors having high risk. Another team in ARIS is working on adding, because Q-Risk 3 has many risk factor and multiple activities, but time will not permit into going on to this. So, Dr. Rastogi, you look at this guideline paper, and this is what is printed. Dr. Sani will comment later. On the left is a low risk and middle is a moderate risk. All the numbers are identical in low risk and a moderate risk. On the right, high risk and very high risk has different number for non-HDL and LDL cholesterol. So on the left, while low risk and moderate risk are identical, I am trying to interpret. On the right, I have a difficulty of distinguishing individual between high risk versus very high risk. This is from same guideline paper, and Dr. Sani is here, but let's see, what do you think about it?
Yeah, I think
you are mute.
your slides were lagging, so now I can see this slide.
Yeah, we got it now.
Yeah, now we can see. Now we can see.
On the left, you have a low risk and a moderate risk has identical numbers.
Exactly.
On the right, I have difficulty separating two individuals between high risk and very high risk. As an average internal medicine practitioner or a young diabetologist.
Yes. So they have categorized this into 4 risk factors. Dr. Sani would be able better to comment over it because he has written these guidelines.
That's right. Yeah. So I will come to that. The very high risk population from diabetologist point of view, we have included those patients. It was not different from ESC. Any diabetic more than 20 years, diabetic with organ damage, diabetic with multiple complication, they have decided to keep them as equivalent to cardiovascular disease. As we know, once upon a time, the paper of that's right, Stephen paper was there. And they say, no, not blankly for everybody, but certain group, yes, they behave like a CAD population or atherosclerotic disease population. And that's why based on that, they kept it below 55. The high risk population is the one where there is a diabetes or hypertension along with one risk factor. That's what we thought. No, because if you have got a single risk factor, like for example, patient has got only diabetes, no other risk factor is there. The pushing of the LDL, if the LDL levels are normal, is not much. If the LDL levels are high, then it becomes one more risk factor. So if you have a diabetes or hypertension with risk factor, there are 5 risk factors which I have said: central obesity, diabetes, hypertension, dyslipidemia, smoking. So these are the risk factors. If anyone, for example, you take the example of diabetic, if the diabetes has LDL above 110, it is a risk factor. I will like to keep it below 70. Diabetes with hypertension, diabetes with central obesity, diabetes with smoking, diabetes with premature CAD history, classical history, premature CAD. Those are the people we have to keep their low level, as you rightly said, Dr. Rastogi, also you said in your comment, to keep it below 70, because the final common pathway of genesis of atherosclerosis is the pushing up of LDL or non-HDL cholesterol. And non-HDL, why I say, because it contains the remnant cholesterol also along with LDL, and also lipoprotein little a cholesterol. So here we wanted to make it a little more stringent criteria to keep it below 70. When we started looking into a person who has got no risk factor, not at all any risk factor, and there we found his LDL is above 110, 120, 130, but he has got no risk factor. There we have said, you keep it below 100. By most of this patient can be managed with some diet plan. That is their possibility. If it not, maybe small dose statin can be there. But if you are alone hypertensive population, single risk factor is there, and LDL is below 100, we did not find any evidence to keep it below 70 in such situation. There is no data of our country. And I discussed at length with the European population also. They, in fact, their normal is 115, not 100. They are little ahead of us. So I discussed, they were laughing. They said, no, we were 115. Why you want 100? I said, we have a data with us. So he said that moderate risk means any risk factor. Like if a person is smoker, I will not like to keep him below 70. But now I started thinking, if a smoker has hypertension, smoker has diabetes, a smoker has central obesity, which is invariably there. I will, if he's unable to give up the smoking, I know if smoker is there, 3 times heart attack, 4 times lung disease, 5 times cancer, and going back to pavilion with hit wicket. We all know all those factors. But, but if this smoker, if he's unable to give up smoking, I would like to keep his LDL below 70. Probably if he has got one of the 5 risk factors. Similarly, I said that this how there were a lot of argument in making this guideline, because we were 22 of us. Lot of brainstorming session came and all that. We could not find any evidence in our country. So for high risk and very high risk is a straight way. Clear-cut answers are given in the guideline. I agree with you, moderate risk and low risk, those are the people where we found they should have been little different for the moderate risk, but we did not find any evidence.
So,
But
Dr.
yes,
Rastogi,
if a
our
person has
diabetics,
diabetes,
our diabetics will get treated with moderate intensity or high intensity. They will fall into high risk or very high risk. Let's see.
They will be.
This is CTT, cholesterol trialist. Larger reduction in LDL will produce larger reduction in risk. Very well-known, well-understood fact. So in people with diabetes, does this guideline suggest a new way of treatment, optimization of statin dose? How do you react to a change in LDL from 70 to 50? On the right, you have a graph of few of the trial which convinces listeners that lower the better.
And I absolutely agree with this. And there have been a lot of evidences that have come up in the past 2 decades that is related to the people with diabetes and even people without diabetes also. So optimization, this term has been recently, optimization, intensification, high intensity statins, all have come up in the past 1 decade. And thanks to all these trials, because all of these trials are event-driven trials. And we know that, well, because being a diabetologist, we see that all of these patients at the end have a demise because of ASCVD. And another factor is CKD also. But presently, ASCVD is definitely the major factor which is causing the demise of these patients. And if these trials have shown that the events, especially the CV or ASCVD events, are reduced by a particular target of LDL, then why not? So now we have ample evidence, and especially the ample number of pharmacological agents also. So if a patient is not able to achieve a LDL target of less than 55 and he falls in the category of high risk or very high risk, you can definitely add ezetimibe. And then you can have further intensify if he is not having targets by using PCSK9 inhibitors. So as a diabetologist also, we are very prone for intensification of the statin dose and also adding ezetimibe. But I would be very frank in saying that I see a lot of inertia with respect to physicians. Whenever I see prescriptions and whenever I see the lipid reports, the patient come to us, the LDL is hovering around 80, 90, is already on 20 milligram of rosuvastatin. So I don't see people adding ezetimibe. I don't know why this is happening. This combination is still very
Correct.
underused, and that is really a concern. And we should work over it to further help our physician colleagues to intensify with ezetimibe. And rightly mentioned by one of the slides by Dr. Sani, that if you first still double the dose of statins, it will reduce only by 8%. But if you add ezetimibe, it can reduce LDL by 16%. And that is a very good advantage, reduce the cost also. Moreover, it will reduce the side effects, the myalgia. And statin intolerance is not uncommon, especially in Indian population, which are vitamin D deficient, which have sarcopenia. And this vitamin D deficiency in sarcopenia, these patients come up with myalgia, and this is one of the common reason. Either they reduce the statin dose themselves or they altogether stop it.
Yeah, I
But
think
Dr. Rastogi, on a similar line is this particular paper which looked at Indian study 2,200 private healthcare practitioners, 15,000 patients, and this is what is in presence of one risk factor, two risk factor, an extremely high risk group. Large majority have not achieved their LDL. This is an international paper. Reasons for non-adherence, patient factor, provider decision, and unknown reason. 30% did not receive statin, 48% received guideline-directed statin. Global data, Doxani must have surely looked at. Over a year, we have discussed in Crevast Academy 3 times why physicians do not do what they are supposed to do. For probably patients do not agree. One of the reasons which turned out to be physician not discussing the role of statin with a patient. How useful is the drug? So any of your expert comment on under usage of statin?
yes, Dr. Sanjeev, I think very relevant. In our paper, we have a chapter on adherence. And we were surprised to know that we did a study on 3,987 patients. Those who are in tertiary care hospital received high dose of statin on day 1 till discharge, and then they were followed up. At 1 year, when we asked them telephonically, we were surprised to know that only 28% patients were on high dose. This is from tertiary care. I'm not talking about the smaller cities and the type B towns. And when we asked them, what is the reason why you are, instead of 40 milligram rosuvastatin today, you're on 10 milligram, or some of them are 20, of course. So the answer, I was surprised to know what the answer came. We specifically asked them, did you get myalgia? Did you have any cost factor which you... Some of them, they say, yes, we look into the media. Sometimes the media is giving them the wrong information that statins are not good, cholesterol is not very important, cause of heart attack, all those factors are there. But the commonest factor which we found, we were surprised to know, they blamed their doctor. They say, डॉक्टर साहब हमारा डोज हमने नहीं कम किया, हम तो खा रहे थे, हमें कोई माइल्जिया नहीं था, हमें कोई कॉस्ट का प्रॉब्लम नहीं था, हमारे डॉक्टर ने बोला आपका एलडीएल 55 से नीचे आ गया है, अब हम 80 से 40 करते हैं, 40 से 20 करते हैं, और 2 महीने बाद आए 20 को 10 कर दिया, विदाउट लुकिंग इनटू द lipid profile. And when we did out of 3,873 patients lipid profile at the end of 1 year, and only on 400 patients, we couldn't do in all patients, and you will be surprised, 396 patients were above 55. I mean, I've taken those patients, those who are not on high dose of statin. So this is the mistake. Who is responsible? Physician inertia, physician's knowledge. He feels once that you have reached less than 55, means you can reduce the dose without asking for repeat lipid profile after 4 weeks. Nobody has done that. And that was one of the reasons why people say that it is good to have a smart stent, but it is better to have smarter cardiologist to look into the future recurrent cardiovascular events of a patient. One of the factors is definitely lab reports, no doubt. But this is also very important. Is it we are afraid of number? 80 or 40 or 20 or something happen. So if I always tell, we have logically told them, if you're showing rising HbA1c, if you're having myalgia, reduce the dose. Or third point, if you're reducing the dose because you found very low, suppose someone has got 30 or 25 LDL, and you feel he is on 40 milligram Rosiva, probably it may not be good. He may get future new onset diabetes or something. If you reduce the dose from 40 to 2, please do not forget to repeat lipid profile after 4 weeks. If it still remains 50 below 55, fine, continue with 20. If you find his HbA1c is going up, add bempedoic acid, because that will prevent the new onset of diabetes in this population. So these are the practical problem which we face into the adherence of statin therapy in our country. This is unfortunate, but this is the fact.
And it is not in our country, it's all over the world.
Everywhere.
Everywhere it is this. So
You're
why
right.
physicians? So it was simple. Why physicians do not prescribe the right statin and the right dose? Dr.
Yes.
Ashu, you want to make any comment or we go ahead?
Just a simple thing, I'll introduce the term physician fatigue. And that's very true for a diabetologist, because at the end, their minds is after glucose. So they already have 1, 2, 3 drug. Then comes antihypertensive, 1, 2 drug. So by the end of the day, they forget about intensification and starting. This is just physician prescription fatigue. And they forget about lipids because their mind is just concentrated on A1C and glucose. For diabetologists, this is very true. The lipid or statins come as a sixth drug in the prescription. So it's already, they don't want to up titrate it, or they forget to up.
That's right. I agree with you. What you said. I think in the diabetic prescription, if some long-standing diabetic population, the first drug should be statin, followed by RAS blocker, and third will be the state of the anti-glycemic drugs. This is what we have learned from our cardiology patient, long-standing elderly population, having CKD, having diabetes, having heart failure. We are very much afraid of hypoglycemia. And if you keep on concentrating on the glucose-centric method of keeping HbA1c below 6.5, 90% of them will get hypoglycemia. So that's why I always tell my patient, keep it 7 to 7.5. But the first drug in the prescription of a diabetic patient should be statin. Because we have a small study, which we did in our country, in our hospital, in fact, very small, 100 patients on each group. Diabetic patient, little long-standing, 5 years plus. They were concentrating on HbA1c below 7. They were on RAS blocker. No, were not on statin. The third group, the second group was, they were on statin, keeping the LDL below 70. They were on RAS blocker. Sugar was not well controlled, 7.5 to 8 something. I can see that the person who are not on statin with good control of sugar, they all entered into my department 10 years earlier, compared to the other group who is having modest control of sugar. I mean, 7 to 7.5 long-standing diabetes, I'm talking about that. But they were not, they were on statin. They prevented the condition. The other thing I just want to tell my colleague, that lipoprotein little a at least should be done once to risk stratify the population. It should not be done repeated, never should be repeated, unless the patient has got CKD or thyroid disease or having septicemia and all that. At that time, LPA may not be time to do that. But once you do a lipid profile, at least once LPA should be done in their lifetime. That is very important.
So, Dr. Rastogi, do you think risk of an individual changes or remains static? I would refer to Dr. Sani. Naveed Sattar, who is a brilliant epidemiologist, said 10-year duration is an MI risk equivalent. As Steve Hafner's hypothesis was challenged, but Naveed Sattar proved through various data and lectured even for Indian people. So, Rastogi, are diabetics with 10-year duration, all of them are for secondary prevention. So, any comment? The risk doesn't change the individual label of hypertension, irrespective of control of A1C or blood pressure. Two important questions on the screen.
It cannot be static, sir. It is very dynamic. It is very fluid situation. The patient is aging. The duration of diabetes is increasing. The target are bound to change. And we know that with increasing age, with increasing duration of diabetes, he is more at risk of ACVD events. Moreover, our belly is also increasing. The abdominal obesity increases with age, no doubt about that. So, with increasing risk factors, the risk of an individual definitely increases, and we have to be very pertinent whenever we see a patient of 40 years and we after maybe 10 years. So, these risk scores may undermine the risk. I believe that, and that need to be borne in our mind and in the mind of the patient also.
Dr. Sani, is there anywhere in guideline for reduction in the dose of a statin?
That's what I said. Two instances. If a patient got myalgia or side
Side
effect,
effects.
or second, a patient who's got metabolic syndrome, pre-diabetic situation showing a rising trend of HbA1c. These are the two logical we say you can reduce the dose of statin. Third, a physician's discretion if the low LDL is too low, but don't forget to repeat LDL after reducing the dose, because you should keep on below 55. That's what the guy. So that is the only area we say that possibly we should reduce the dose of statin, no doubt in that, in atherosclerotic cardiovascular disease. And you have very rightly said that most of the diabetic population will need modest doses or maybe a high dose of statin to keep the levels below 70. Otherwise, they are going to get the recurrent coronary event. Regarding the dynamicity of the risk, yes, it is there. This is what the most of the risk scores suggest now, that once you are managing patient very well, look for their risk score again. If the risk score is coming down or it is same, that will help you to adjust the doses of all the three important risk factors: diabetes, hypertension, and lipids.
But sometimes the risk does not get expressed. If a patient
Yes.
develops microalbuminuria in the course of diabetes,
Yes.
automatically risk has changed, which the
Changed.
score will not tell us. A
Yes.
last question on the feasibility or utility of non-fasting, because though the guidelines said non-fasting on admission, internationally this is very valid. People don't travel, not easy. Our lab phlebotomist and people know that 12 hours fast. Forget non-fasting. They insist on a 12-hour fast. So you can, again with a biochemist, take up this point also.
That's right. You're right. You're very right. Good suggestion. I think this is what we are going to do on 8th of August when we are having the All India Biochemist Laboratory. We're showing about this. And non-fasting is a very important, because what has done, I did for 7-8 years ago, the guidelines when it came from other countries, from my hospital, when I changed the rule and also spread this knowledge to all my 300 physicians, those who are working in our hospital, what I found, within 1 year, there was 22% increase in lipid test. Number one. Number two, the good answer with the feedback I got from laboratories was also that early morning rush of patient was also reduced. Because you can go and get the test done any time of the day. And the data from the Copenhagen study on almost 2 lakh population is clear that the triglyceride increases by 26 milligram, HDL, total cholesterol, LDL cholesterol, nothing changes. And the most important thing is, if your TG is high, above 400, 450, we do need fasting, no doubt. In there, we suggest them to go for fasting. But suppose if your TG is little high, then this fasting and non-fasting does not matter, because total cholesterol and HDL cholesterol are not changed. So if it is not changed, we are looking for non-HDL. Non-HDL is not changed with the diet, with the fasting or non-fasting. And we keep on targeting non-HDL in such situation, particularly diabetic patient, those who have controlled diabetes, but in spite of that, the triglycerides are high.
So final comments from Dr. Rastogi. We have exceeded time. And so I don't think I should take any more questions. Diabetic people are doing fasting blood glucose, so automatically lipid gets estimated. But we recommend 8 hours is good enough. We don't need 12 hours. People should eat at a regular dinner time and a regular morning sample. That's
Sir,
how we live.
I think that in current era, there is no indication of any of the fasting tests, because now we monitor diabetes by HbA1c, which doesn't at all require fasting. So if you are taking a single sample, the patient come at any time of the day. So forget about lipids. Even for diabetes per se, we don't need it. Patient get a fasting by glucometer, that's good enough. And they can come at any time, as Dr. Sani was mentioning. So we don't insist now on any of the fasting samples. It's not at all required for any of the present tests.
only one test is required fasting, that is fasting sugar.
That they can do by glucometer.
There is no
Yes.
need for a laboratory. With this, I would hand over to Khushbu Patel at Aries for the final concluding remarks.
Thank you, Dr. Sanjeev, for very nice. You have done very well. And Dr.
I
Ash,
tried to do a justice to
yes,
clinically relevant questions which
yes,
comes in the
yes,
mind of a physician. You
yes,
have put in very, very hard efforts to compile all the available data and put it in a way it could be given as a guideline. And probably we will make a progress in a coming decade, built
yes,
up further in
yes.
practice on the guideline as an initial document.
That's right.
Khushbu,
After 2 years, we will be again having updating the guidelines. This is what we have written in the end.
Khushbu
I would
Patel.
like to add one point here, wherein we have seen that some of the barrier in terms of using the optimum dose comes from the physician side. Some inhibition, or we can say the practicality, may be a dropout from a patient side. One initiative which we have taken as a company is by making rosuvastatin 40 and 20 mg at a price of 10 mg, with an intent that patients who are eligible and should be continuing this therapy for lifelong should not be downgrading just because of the price constraint. So currently, as we are aware, 40 mg rosuvastatin is around 55 rupees, and 35 rupees is the cost of 20 mg. So if that is becoming a barrier, so the cost is optimized and all the three SKUs are at same price. So that could be one of the reason they should be more motivated to use 20 mg and 40 mg if required, if patient is eligible.
And
So
the combinations are, yeah. And
Aries
combinations,
combinations
makes
are
it
also at a similar,
yeah,
same price, whether it
because,
is 10 ezetimibe, 20 ezetimibe, 40, 20, 10,
yeah,
all same. Even CV and gold, 20 mg, it is all same. So based on the eligibility and the, as you have mentioned, the scoring, high risk, very high risk, a doctor can decide.
even fenofibrate combination is at similar price.
Yes, all the
So
SKUs, 10, 20.
Aries team has to popularize this concept that select any of them. They are all at the same price of 10 milligram, which is roughly 18 rupees a pill per day.
yeah, that's good.
Thank you, Khushbu.
Thank you very much. All the
Thank you very
speakers,
much.
Dr.
Thank you.
JP Sai, Dr. Ashu
Thank you.
Astoki sir, Dr. Sanjeev Shah, and thank you all the delegates for joining with us. And good night. Have a great
Thank you.
evening ahead.